Good evening, everyone. Good evening, sir. Thank you so much for coming. Today, Dr. Atif is with us. He's finished DMD Internal Medicine from CMC, worked briefly in emergency medicine, completed neurology, neurology DM, and he is working in the Department of Neurology as Associate Professor. Thank you so much, sir, for coming. Over to you, sir, for the lecture.
Hello everyone, good evening. So we'll be talking about Parkinson's disease, a little bit on pathophysiology, diagnosis and management. So we'll be covering mostly the learning objectives. We'll be learning to know the brief pathogenesis and pathophysiology. Will not delve into great details of Parkinson's disease. A lot of new information has been out in the last 5 years or so. Just enough to help us to an approach to diagnosis in Parkinson's disease, and how to use the criteria, how to use clinical information to come to a diagnosis in Parkinson's disease. Uh, that's something which we'll stress a little bit on a clinical diagnosis of idiopathic Parkinson's disease. We'll also learn a little bit about early management in Parkinson's disease. Uh, we will not cover details of pathology. A lot of molecular biology uh, is known now. A lot of new things have been discovered or rediscovered, emphasized in the last few years. We'll not cover those. We'll not cover rare types of Parkinson's disease. We'll just maybe a little bit touch on the subtypes of Parkinson's disease, but not delve too much inside the. Additionally, we'll learn a little bit about advanced Parkinson's disease management, maybe just a slide or so. Now, uh, the biggest problem in learning Parkinson's disease is, of course, you have to see patients. We have a lot of videos with us, but then because this is going to be on a public channel, we can't put those patient videos online. So do come to our department anytime. We all have a lot of videos which help a lot in learning, and obviously the best thing to do will be to see patients. In any of our OPD, we'll at least have a few Parkinson's disease patients. On Wednesdays, we have a movement disorder OPD where we'll have at least 4 to 5 Parkinson's disease at any given time, on any Wednesday. Right. So we'll jump into the nomenclature first. Uh, so a lot of names have been called, a lot of isms and this and that. So right now the word that we use mostly for the disease of Parkinson's disease is idiopathic Parkinson's disease. So what looks like idiopathic Parkinson's disease but it's not, or we are not sure, then we can call it Parkinsonism. How to come to that diagnosis, I'll come to that. So idiopathic Parkinson's disease also now can be considered as a sporadic idiopathic Parkinson's disease or a genetic Parkinson's disease, where genetic uh, 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 a mutation that can cause or predispose to Parkinson's disease may be called a genetic Parkinson's disease. We also have a nomenclature called young onset Parkinson's disease, typically used for less than 40 years, but some people wish to push it a little bit further up till 50 years of age because it has slight differences in management as well. We again then the patients which do not fit into criteria or diagnosis of idiopathic Parkinson's disease, we call them atypical Parkinson's disease and or atypical Parkinsonism, which is the preferred term, and there are a few differentials in those. Now we can go into subtyping Parkinson's disease, but it doesn't really make a difference. The two large predominant subtypes which we see often are tremor predominant or a gait predominant subtype. Uh, so because there are so many subtypes, whether to consider all idiopathic Parkinson's disease as one singular disease, or there's a push to make it as a syndrome rather than a disease, and then look for differences and causative causations in variations in each of the more phenotypic variations. So let me just ask a few questions, and you don't have to really answer it here, or just answer it amongst yourself. What is the best way to diagnose Parkinson's disease? Okay, and the second question is, if the treatment of Parkinson's disease is largely symptomatic, is there any therapy that can prolong life expectancy? So we know that the disease doesn't change, it's a neurodegenerative disease. Is there any way how we can prolong life expectancy in a patient who comes with Parkinson's disease? And if I say yes, can you think of one reason how? Okay, so just a touch on how to do an investigative study in any neuroscience. There are multiple layers. A person who does molecular neuroscience may not know much about clinical or circuit-based neuroscience. So generally, we have multiple layers. You start with molecules in the form of neurotransmitters, metabolic parameters, and cycles, etc. Then you jump one layer, zoom out a little bit. You have cell and cell wall. In neuroscience, you have in the form of synapses, the neurons, various neurons, the neurotransmitters that they have, they choose, they secrete. You have the non-neuronal cells, the glia, the immune cells, which are very important. So those form the cell and cell wall level of neuroscience. All of these, they form circuits and networks. Neuronal as well as non-neuronal circuits and networks. The common examples that we have is the direct pathway, motor pathway, the Pepper circuit for memory, etc. And all these circuits and networks, they form systems. So we have visual system. We have the motor system, somebody who walks. So, and all these systems, they eventually form an individual. So Parkinson disease is an excellent disease to study all levels of all these levels, because you have at a molecular level you have a relative dopamine deficiency. You have a alpha-synuclein dysfunction. Whether it leads to toxicity or not, it's not clearly known, but possibly yes. And you have other neurotransmitters as well, not just dopamine. You have norepinephrine, you have acetylcholine, serotonin, which are suspected to cause the non-motor symptoms. Then you jump one layer ahead. You have a cellular level where you have pigmentary neurons in substantia nigra, which are lost early, and then later on the rest of the brain also starts to show reduction in the neurons as well. And then you jump one layer, you have the direct and indirect pathways. Later on cognition as well gets involved. And there are multiple systems, the largest and the predominant of which is the movement system. So we'll just see, instead of blank slides, we'll just see some pictures. So this is a section at the midbrain level which shows substantia nigra. This is how it looks like, and the right one is normal, and that one is where we see the dark layer which was here, that is completely gone. So those are melanin producing cells which are lost in Parkinson's disease. You can see that same thing in tyrosine hydroxylase stain, where we see the normal staining of in a normal person, whereas in a patient in PD we can see the cells are completely gone, and you can see some inclusion bodies which are intraneuronal Lewy bodies. So this is at the cell and histopath level. Molecularly, you have misfolded proteins, which is alpha-synuclein, which form oligomers, fibrils, and finally they form Lewy bodies, which is the pathological hallmark of Parkinson's disease. So as you go deeper and deeper, you have multiple layers. This is just one simple outlook of all the pathophysiologies which are involved. But you don't have to mark the entire slide. Just remember that there are genetic causes. So some mutations which may cause Parkinson's disease or may just predispose a person to Parkinson's disease. And in addition to that, there may be an additional insult in the form of, well, the well-known ones are rotenone, paraquat, MPTP poisonings. There may be others which we don't know yet. So there are multiple hits, or there may be one causative mutation, and that may lead to eventually Parkinson's disease. So the end dysfunction that is noted in most of the patients is mitochondrial dysfunction and the proteasome lysosome dysfunction, which leads to alpha-synuclein deposition and hence toxicity, neuronal degeneration. So once the process starts, it's generally progressive and it keeps on spreading from one part to the other, and that's how Parkinson's disease becomes a neurodegenerative disease. We step one layer ahead. We go to the circuits. This is not the only circuit. So cognition gets involved, vision gets involved, autonomic pathways get involved, but major the majority of the motor manifestations are explained by these two circuits, which are the direct and the indirect pathways. So the function of the direct pathway is to increase movement. So somebody who is walking, the initial the commands start from the cortex, they go to the striatum, and then finally come back to the cortex. The initial when you start a movement, for example walking, the initial part is just taken care of by the cortex and the spinal thalamic tracts, corticospinal tracts, and the movement of the muscles. But then to continue doing these movements, you need the basal ganglia, continuous movements, you need basal ganglia to come in. So the initial few steps may be very much voluntary, but then the continuation of the steps will be through basal ganglia derived movements. So from the cortex, as a signal goes to the corticospinal tract, one also goes to the striatum. In the form of direct pathway, it comes to the GPI via D1 receptors. Then it goes to the thalamus and to the cortex. This entire thing finally is a stimulatory pathway. So it will keep on stimulating the movement. You also have to inhibit a particular movement. For example, when you are flexing at your elbow, your biceps is supposed to move, but your triceps is supposed to relax. So that relaxation is provided by the indirect pathway. The inhibition is provided by the indirect pathway. And also in general overall movement programming, whenever you have to reduce a particular movement, the indirect pathway becomes dominant. So that goes through the globus pallidus externa to the subthalamic nucleus, and then circuits back to the GPI and thalamus. This additional steps makes it double negative. So this entire pathway will cause an inhibition in movements. So all you have to remember is that direct pathway goes directly to GPI and causes stimulation of a movement, excitation of a movement, and their indirect pathway causes inhibition of a movement. So now what happens in Parkinson's disease, the problem is not in the direct or indirect pathway, the problem is in the substantia nigra pars compacta, which is a source of dopamine. So all the dopamine comes from substantia nigra, it goes to the striatum. Whatever stimulate whenever D1 receptors are stimulated, the direct pathway gets involved, gets activated. Whenever the D2 pathway gets activated, the indirect pathway gets excited. So now in Parkinson's disease, we have a deficiency of dopamine itself. So both D1 and D2 receptors are not excited. So the direct pathway is affected, leads to reduction in movement overall, as well as the indirect pathway is not activated, and that leads to mostly that leads to tremor. So the systems that are affected are largely the motor system. That is the core of crux of Parkinson's disease. The predominant movements that are affected is because of a motor system involvement. Now, because we have a good grip on motor system management of bradykinesia and tremor largely, we slowly have come to realize in the last 10-15 years that a lot of non-motor symptoms are also involved, and they are largely divided into 4 groups: the cognitive and psychiatric problems, the autonomic dysfunction, the sleep problems, and sensory processing difficulties. We'll come to each of those. Now, in Parkinson's disease, the crux of the problem is bradykinesia. It's not tremor. Although tremor is the thing that we most commonly associate Parkinson's disease with, it is not the predominant problem. So the hallmark is bradykinesia, and when it comes to diagnosis, bradykinesia has more importance than tremor. So bradykinesia is slowness in layman's term. It's a little bit more technical. It becomes you say it is decremental movements with respect to time. So the range of movements keep on slowing down. Now, akinesia and hypokinesia are very close terms. Uh, uh, so which may mimic bradykinesia, but however they are slightly different. So a normal, if you can see my video, uh, uh, right. So let's say we want to do finger tapping, and you request the person to close the fingers completely and open as much as possible, as wide as possible. So this is finger tapping, and you do it as fast as possible. So a normal speed and a normal amplitude, right? If this entire thing is the amplitude and the speed, this is normal, right? Now if my entire process is slowed down, instead of going like this at this speed, good speed, which is normal, if my entire process slowed down, this is hypokinesia. So I am slow, but my amplitudes are good, right? Or if I am complete, my amplitude is reduced and movements are slow, then that you may call it akinesia. Technically, bradykinesia is reduction in movements in the range of movement. So you start with normal, and then slowly it becomes slower and slower, right? You start like that, and then the pace becomes the movements. The amplitude of movement reduces gradually. So now you may get akinesia, hypokinesia in spasticity. So some spastic disorders which are not like a stroke, rather a differential diagnosis of someone who presents with spastic paraparesis or a stiff person syndrome. Sometimes they complain of slowness, but it's not a true bradykinesia, it's a hypokinesia rather. Very rarely you may see element weakness, but you should be able to very clearly discern that this is not bradykinesia or hypokinesia, rather it's motor weakness. And very severely depressed patients may have drastically reduced psychomotor movements. Their face will be down, they won't be looking up, they'll be walking very slow, movements will be very slow, and you have to make sure that that's not the case. Other rare differentials are hypothyroid slowness. Very rarely you may have sometimes dystonia, which posturing of a limb, which causes reduction in movements, but that's not true hypokinesia again, bradykinesia. Catatonic patients again will be really rigid. They may not move much, and you may think whether they have actually bradykinesia, as well as stiff person syndrome. Where all you can look for bradykinesia, you can look at the finger tapping. This is the easiest and the best way. Then you have hand movements. You open and close your hand, and a Parkinson patient will start off by opening the hand fully, but then gradually they'll go like this. The hand may not improve, open completely. Pronation, supination movements, they'll be able to do completely initially at good pace, and then they'll come down. They won't be able to do at all. Similarly, arm bradykinesia, you can notice that when a person is walking, what is the range of movement of the arm. Foot bradykinesia, we tap the foot, we tap the entire leg, as well as see the patient walk and see the stride length. Right. So this is how it looks like. So a normal subject, these are basically motion detectors which are stuck to a person's limbs, and a normal person will keep on having the same movement. So you start with the cortex, and then the direct pathway takes over, and you have the same movement throughout the same range of movements throughout the activity. Whereas in a Parkinson's disease patient, you can see the reduction in movements, right? The same thing happens with handwriting as well. Now the problem is in advanced VD it becomes a little bit difficult to pick up because the movements will be very minimal to begin with, right? So, but you may still be able to demonstrate some amount of bradykinesia. The second most obvious manifestation is tremor. So it's a slow rest tremor. Now, this is how we see a tremor in the lab. So clinically, a tremor should be equal in both axes. So if it's a flexion extension tremor, it should be like this, or if it's a supination pronation tremor, it should be moved. So across the axis, the movement should be equal. So if it keeps on going like this, like this, like this, it's not a tremor. It's actually a dystonic tremor or a spasticity. So for example, you can see this in the this diagram what we'll try to show here. So this patient has come with a tremor in one of the hands, and we realize that the hand that is involved is the left hand. So if you see this part, so these are accelerometers which are stuck on motion detectors, and you can see the nice sine wave-like pattern of the movements, right? So that suggests this is a tremor involving the left hand, whereas in the right hand that is not there. Now, when you stick, to demonstrate very well, you have to stick a surface EMG marker on two muscles which are antagonist to each other. So here is the flexor carpi radialis and the extensor carpi radialis, and this line suggests muscle activity, right? This when the muscle starts firing. So this is when the FCR starts firing, then there's rest, then there's fire, and then there's rest. And the ECR is the antagonist muscle that doesn't fire when the FCR is firing. So there is alternate contraction and relaxation, and this gives rise to this tremor, right? And at the same time, we see the right side is normal. This is a Fourier transform of the waveform. This transform basically suggests what is the place where the tremor is maximum, and we see that this is at around 2 Hertz. So this is 2, 4. So somewhere here will be 5. So this is around 5 Hertz tremor. Right. I'm sorry for that. Yeah. Okay. So the differentials for this tremor, for any tremor, is an essential tremor, but the essential tremor is a much faster tremor. So what you get here is 2, 4, 6, 8, 10. So this around up till here is 1 second. So you have around 1, 2, 3, 4, 5 times the muscle fire. So 5 Hertz is the tremor rate. In an essential tremor, you'll get much faster, around 8 to 10 to 12 Hertz. The other differential is a drug-induced tremor, which you have to take a history and find out. It may mimic completely like a Parkinsonian tremor. And the final slow tremor differential is the Holmes tremor, which is also a Holmes tremor, but which is also a rest tremor, but it appears at rest as well as at action, and the frequency usually doesn't change, the amplitude increases. So that's how you differentiate Holmes tremor. Now rigidity, although we say classically cogwheeling, the requirement is not cogwheeling, the requirement is actually lead pipe rigidity. So if it is there, that's enough. You don't have to demonstrate cogwheeling. So you see the rigidity, when you check for tone, the increased tone is demonstrated at all levels, and there is no velocity dependence. Now other motor phenomena are gait. You can see a person with Parkinson's walk, they have a short shuffling gait, arm swing is reduced, stoop, they have a face which is blank, there is no expression. They'll have freezing later on, they may have a tremor when they stand up, and very late in the disease they may start having falls. The handwriting bradykinesia manifests itself as micrographia, reduced eye blink, hypophonia and dysphagia. Now, both motor and non-motor symptoms are generally present at the outset itself, and both keep on increasing. Generally, the patient's present when the motor symptoms start, because that's when they realize that something is really wrong. The early non-motor symptoms are usually non-specific, so that's why the core of the diagnosis is based on motor phenomena. However, some non-motor symptoms are included, and we should be aware of these. Commonest is not the commonest. The most burden is, of course, put by the cognitive part of non-motor symptoms. In the initial phases, you will see only a mild execution dysfunction. So you give them a clock to draw, they may draw it wrong. They may have a memory problem, but it's not a memory formation that is erratic. It's a procedural memory. So it's an immediate memory that is lost. So that is the more of a problem. They may have a tip of the tongue phenomena, and they may have improvement in memory with cues. So the subcortical type of memory dysfunction. Depression and anxiety is very, very common in Parkinson's disease, and it takes away a lot of quality of life. So screening for depression and anxiety should be done at every visit. A lot of patients do have hallucinations, delusions, and frank psychosis as well, which can be managed easily. Autonomic symptoms. So when I asked you few things that can improve prolonged life in patients with Parkinson's disease. So till now, all we have done is improve the quality of life. But autonomic dysfunction management prolongs life as well. So you have orthostatic hypotension, which can be very dangerous, as well as you have supine hypertension. So a patient usually comes to an OPD and you check the blood pressure and it's fine, and you let the patient go. But when the patient lies down, the blood pressure goes up to 180, 190 systolic. It's a common thing in supine hypertension. So we should be able to pick that up as well and manage it, because if blood pressure goes uncorrected for a long time, it increases the cardiovascular mortality. The other place which will reduce life expectancy is the bladder dysfunction, especially when there is a bladder retention. So that is not very common. The commonest thing in bladder manifestation is nocturia and urgency and urge incontinence. After some time, patients will have depressor hypoactivity. Some patients may have an additional prostatic problem. So they have a bladder retention. The post-void residue goes up. That can lead to recurrent infections and early mortality. Constipation is another autonomic problem in erectile dysfunction. These both are very, very common. Sleep, again, there is a very specific sleep problem which occurs in most of the synucleinopathies, and that is REM, sleep behavior disorder. So this is described as the patient gets up in the night trying to shouting at someone, or trying to call out to someone, or just tries to mimic what he was doing in the night. So in his sleep, he'll be either typing out or writing or lecturing someone, something like that. So if you get that history, that's a very specific history of a synucleinopathy, and it is one of the new additions in the diagnostic criteria as well. A lot of patients do struggle with insomnia as well, early daytime somnolence, and sometimes the patients may have obstructive sleep apnea as well. Now, sensory processing, the two most common things are hyposmia. Hyposmia is so common that it can be used as a screening test as well. So you give them 5 different things to smell and just identify it. And most of the PD patients will not be able to identify it correctly. Pain, a lot of patients present with pain rather than tremor, and this usually is a shoulder pain or a back pain. And the pain has multiple causes. So the most common is the rigidity, which reduces movements, restriction of movements, and that persistent posturing give rise to pain. But there can be a central pain as well, so that requires management. Now, this is a phenomenon called pareidolia. So normally we have a tendency to see faces in a lot of things. So these are photographs where people have tried to see faces, but patients with Parkinson's disease who have cognitive impairment or some amount of psychosis, the most common manifestation is pareidolia. So they see faces even in like flowers. They'll see a lot of monkeys or people around, and they'll see like a crowd. You have to ask this out, and often you'll be surprised. You'll be surprised how frequently they have it. Right. So clinical diagnosis of Parkinson's disease is the diagnosis is largely clinical, right? We have some investigation which may help us, but all the criteria, the process is largely clinical. We start with the motor first. That's the crux of the problem, and the must requirement is the bradykinesia, and bradykinesia with either rigidity or tremor is enough to say Parkinsonism, not Parkinson's disease, Parkinsonism. Right. So we have learned how to diagnose bradykinesia. We learned how to diagnose tremor and rigidity. Earlier diagnostic criteria had postural instability also as a part, but now it's been removed out of completely. Once you've done that, we have to rule out certain diseases which do not, completely rule out Parkinson's disease, and the most common ones are the Parkinson. So you have cerebellar involvement in MSA, supranuclear gaze paralysis in PSP, frontal dysfunction, aphasia in frontotemporal dementias, lower limb restricted Parkinson's disease in which stays in the lower limb for more than 3 years. We have other differentials for those. We should make sure there is no drugs taken prior to this, which may explain Parkinson's disease. If there is absolutely no response to levodopa, we can rule out Parkinson's disease. There is no higher order sensory dysfunction, cortical dysfunction like apraxia, aphasia, which may suggest a corticobasal dysfunction. A normal DAT scan is good to rule out Parkinson's disease, although an abnormal doesn't always rule in. In the new MDS criteria, there is one loophole which a physician may use when he or she thinks that an alternative etiology may be possible. For example, a physician thinks they may have a hereditary cause like Wilson's disease or something. So they may not. They may say that I can rule out. So this is a detailed list of the previous list, or whatever I have told you before. Now in step 3, you have something which you will know prospectively. Now this is the most important step. So a person comes to you on a day, and you make a diagnosis, and you record it for many years, and the patient dies after, let's say, 15 years, and you do post-mortem. So if you made a diagnosis of Parkinson's disease using these criteria, it's likely that 75% of the times, if you have a good clinical acumen, you will be right. But if the person had followed up with you for many years, and the last diagnosis as compared to the first diagnosis, if you compare the last diagnosis, that's almost 100% correct. So clinical follow-up is the most important factor to diagnose correctly idiopathic Parkinson's disease, and this has been noticed, and an importance has been given. So, for example, a person who has unilateral onset and persistent asymmetry on the side of onset is most. So that gives more strength for a diagnosis of Parkinson's disease. Rest tremor definitely emphasizes Parkinson's disease, and it's a progressive disorder. So if you follow a patient for 5-10 years, and you see that the patient is started off with left side, now right side, then face, jaw, dysphagia, dysarthria, non-motor symptoms, then you know that's a progressive disorder, and you can more confidently diagnose Parkinson's disease. If there's an excellent response to levodopa, so there are other diseases also which may have a response to levodopa, but in addition to other things, then you can diagnose Parkinson's disease. Levodopa-induced chorea, it usually occurs after 4 to 5 years, maybe or more, and once those set in, that encourages you that this is the Parkinson's disease only and nothing else. Levodopa response that persists for more than 5 years also. A lot of diseases like PSP-P, which may have a very good response to levodopa at the outset, but usually by the 3rd, 4th year, the response dies off. Even in some patients with MSA, they may have excellent response to levodopa, or maybe a 50% response to levodopa, but after 3 to 5 years, that goes off. So around 5 years or more, the levodopa response persists, then you can safely say that the patient has Parkinson's disease. A clinical course of 10 years or more. So most of the atypical Parkinson's, they don't last for such a long time, and very prolonged course may help to diagnose Parkinson's disease. Now there are certain red flags, so they don't necessarily rule out Parkinson's disease, but you may consider some other diagnosis. So rapid worsening gait, rapid bulbar, respiratory involvement, very severe autonomic failure, recurrent falls within 1 year, disproportionate dystonias, and when there are non-motor features which are completely absent up to 5 years. So sleep dysfunction completely absent, autonomic dysfunction completely absent, hyposmia completely absent, psychiatric dysfunction completely absent, you can rule out Parkinson's disease as well. So pyramidal pathway problems and symmetric or persistently symmetric Parkinson's, these are red flags. So they don't mean that Parkinson's disease can be ruled out. You can still, but you have to be careful in following up in patients. So overall diagnosis is largely clinical. imaging, we saw that dopamine scanning can be done. MIBG's cardiac SPECT for denervation can be done, and if it is normal, there is no denervation, that is a red flag. There is a physician opinion loophole as well. And you will notice that dementia is not an exclusion criteria. So DLB used to be one of the atypical Parkinson's disease, but now it is considered to be the same as Parkinson's disease. And there can be some autonomic. So as soon as you find autonomic dysfunction, do not jump to diagnosis of MSA. It may still be Parkinson's disease. Right. So these criteria are largely clinical. There is no pathological confirmation. There is no role of subtypes in PD in the criteria. There is no role of biomarkers, which are coming up in a big way. And path diagnosis is also not there. So as we said, the differentials are atypical Parkinson's, largely in these 4 forms. Secondary, these are, as internal medicine graduates, you should be able to pick up most of the secondary Parkinsonism. So the commonest ones are drug-induced and vascular that we see. This is a slide from Harrison's, so you should know this. Lower body predominant Parkinsonism, normal pressure hydrocephalus, and vascular Parkinsonism. We often see carbon monoxide related Parkinson's. So a patient will have slept in a room in cold with fire burning, and they would have lost consciousness, and a few months later they start having slowness. So that's carbon monoxide related PD. So these are some of the scans which are not really required to make a diagnosis, but in alternative diagnosis. So in a Parkinson's disease, scans may be completely normal. There are some small findings, but we will not discuss that. So midbrain atrophy in with a penguin sign in PSP. This is vascular Parkinson's, suggestive of small vessel disease. A patient with normal pressure hydrocephalus. You have a preterminal hyperintensities in multiple system atrophy, and hot cross bun sign again in multiple system atrophy. So this is how a DAT scan which we have looks like. So normally you should see the corpus striatum as a comma shaped entity. In early Parkinson's, the comma shape becomes asymmetrical, and later on becomes dimmer and dimmer. This is the most important slide, which gives on a x-axis the time in years, and on y-axis is the degree of disability. So this is a time when usually a patient will present to you with bradykinesia, rigidity, tremor. But if you ask a history previously, they may give history of constipation, REM sleep behavior disorder. They may have early daytime somnolence, hyposmia, and depression. As time progresses, you can see that motor manifestations still are problematic, but the psychosis, cognitive problems, even the non-psychosis, bladder symptoms, dementia, orthostatic hypotension, those also become really disabling. So almost twice as disabling as motor symptoms, almost 20 years down the line. So management is, of course, you have to improve the life, reduce motor, non-motor problems, as well as reduce drug and non-drug related complications. So this slide gives us most of the actions of mechanisms of action for drug therapies. So the cornerstone of therapy is levodopa. So this neuron is basically coming from substantia nigra and synapsing with the corpus striatum. So the dopamine receptors are here. So dopamine is formed in the cells from tyrosine, becomes L-dopa, becomes dopamine, and comes to the cell membrane, gets released, gets picked up by the dopamine receptors. Now this gets taken up again, as well as is degraded here itself using COMT, and once it comes to the neurons, it is degraded using MAOB, monoamine oxidase type B, into levodopa, which can be reused again. So when we give levodopa, basically it goes into the presynapse directly and gets converted into dopamine and gets released, right? So that is why it is the core of management. Now other drugs that we may use is the MAOB inhibitors, which again increase the levodopa by reducing the degradation. we may use dopamine agonists, which come directly and bind to the dopamine receptors on postsynaptic areas. We may reduce the degradation of dopamine by giving COMT inhibitors. And amantadine, which has dual actions. The core of therapy is levodopa-carbidopa combination. So whenever you suspect it, you start it off. It serves as a therapeutic trial in diagnosis as well as in management. So start in the first time that you see the patient. So start with small dose, maybe half tablet twice or half tablet thrice, and gradually keep on increasing as you see the patient. And you'll notice that there is a improvement in bradykinesia and rigidity, which is more than tremor. It's the first choice of drug unless until contraindicated, and it may be the second choice in young onset Parkinson's disease, because patients with young onset, sometimes they'll have a lot of fluctuations with levodopa. So initially you will have good response to levodopa. So the top blue part is the off time, that is the patient is symptomatic, and the below blue part, the top blue part is on dyskinesia. So this is a side effect related type. So when the drug levels are low, the patient becomes symptomatic, and the drug levels are high, the patient becomes toxic to this. And with progression, what happens is that the therapeutic window closed down. This is probably because the suspected that this the levodopa doesn't just take this route, but also gets stored here. So that provides a large window for therapeutic therapy. And as this window closes down, you will have either a patient who is off, has no symptoms, has very severe symptoms of tremor, rigidity, and bradykinesia, becomes normal for a very short time, and then suddenly goes into the dyskinesia phase. So this is called on and off fluctuation. So that frequent dose adjustments are required. You have to keep increasing the dose, or splitting the dose, or reducing and giving it multiple times based on the patient response. One common thing that you see early on is nausea and vomiting, or when you increase the dose suddenly. This usually is transient and rarely requires dose adjustment. We always say that you should take Syndopa before food, before meals. If a patient has very severe nausea vomiting, you can tell them to take it after food for some time. You can add on domperidone also for a short time. There may be autonomic dysfunction which may get worsened with levodopa initially, but that's also transient, and significantly that also improves with domperidone. So later on, all the motor fluctuations and dyskinesias come in, and they require much more stringent adjustment. Sometimes you have to admit patients just to adjust the drugs. Other drugs which are helpful are MAO-B inhibitors. So they have a mild response. They will reduce tremor, bradykinesia, and that's why they are really helpful. Generally, they are prescribed early into the disease. Later on, they may not be as helpful, but sometimes we'll have to continue those. After a decently high dose, for example, 4 times a day of levodopa-carbidopa combination, we generally add a dopamine agonist as well, because it gives a longer duration of action. The common drugs are pramipexole, ropinirole, bromocriptine, which are available here. Apomorphine can be given as an injection or an infusion, and rotigotine, which we don't have yet, but the advantage of rotigotine is that it can be given as a patch. So you just stick a patch or 2 patches and they last for 24 hours. There are 2 problems which are associated with dopamine agonists. One is drowsiness and narcolepsy. So patients, when they are driving, they may fall asleep. So we have to get a history whether they are doing that, then we have to reduce the doses. Second is impulse control disorders, which can happen with levodopa as well, but are more common with dopamine agonists. Right. They may be used earlier in young onset Parkinson's disease. COMT inhibitors, we don't use tolcapone, generally we use entacapone, and that helps in reducing off time rather than dyskinesias. If dyskinesias are more of a problem, then we reduce the dopamine dosage, maybe split into half more frequently, and add amantadine that helps more for dyskinesia. Central anticholinergics like Pacitin uh, help a lot with tremor reduction, but not as much as for bradykinesia. The problem, of course, is that they have anticholinergic related adverse effects. We should always stress on non-medical therapies because they do lead to almost 20 to 30% reduction in symptoms in some patients, which is a huge amount considering the number of drugs that patients have to take for a long time, as well as with no adverse effects. So we routinely send patients for physiotherapy where they manage the rigidity part, range of motion, pain relief, and which and assist the patients in performing aerobic exercises, which keep the patient independent for daily activities for a longer time. We send them to occupation therapy so that the patients can learn activities of daily living despite having dysfunction. Very severely affected patients learn transfers from one place to the other. We send them for a cognition stimulation program, hand function, and in early disease, sometimes biofeedback helps for tremor. Speech therapy is required when the patient has a disabling dysarthria or dysphagia, or in later diseases when aspiration becomes a problem. So, in those patients are taught what all tricks to avoid aspiration. Advanced therapies. So, lesionectomy, paludectomy was practiced even before levodopa became popular. This went down once the levodopa started having a very good effect. The rates of lesionectomy came down. What took over surgical management is deep brain stimulation. So instead of activating the circuits with dopamine, we put in a DBS lead on the subthalamic nucleus generally, and that helps in restoring functions for a long time, up to 5 to 7 years at least. Now, lesionectomy had gone out, but it's coming back again because a non-invasive form of lesionectomy is now gradually getting available. It's not there in India yet, but probably will come. So, it is not yet come because it's very cheap, so no one wants to invest in it a lot. So, it's MR guided. You just target the subthalamic nucleus and you focus ultrasound with many sources, around 1,000 sources, and you just like making a lesion, but there's no incision. Temporary relief, for temporary relief, apomorphine infusion can be used. The problem is that apomorphine causes a lot of vomiting, so almost 50% patients they have to come out. Other option is to have a levodopa carbidopa continuous intestinal gel. So it's a device which can be placed by intervention radiology or gastroenterology, and generally it because it's a continuous infusion, patients, even if they forget to take the medications on time, some background levodopa is always available. So any disease modifying therapy. So this has come up in the last in 2019. So glucocerebrosidase is an enzyme which is severe deficiency of which causes Gaucher. But some mutations they lead to a mild enzyme deficiency, and they don't present as Gaucher's disease, but after some time they present as Parkinson's disease. These patients they have some specific differences, like they have early cognition involvement, they have early autonomic involvement. Otherwise, they appear exactly as Parkinson's disease. So these patients were picked up, and there are two ways you can overcome the reduction in glucocerebrosidase activity. One is you replace the enzyme itself, or you give an activator of the enzyme. So ambroxol was found to activate glucocerebrosidase. It is very readily available. Ambroxol is a cough stimulant which is very commonly used, and it was found to increase the glucocerebrosidase activity, and that leads to reduced synuclein oligomers, which has been demonstrated pathologically as well. Now, disease prolongation as well as motor and as well as non-motor symptom reduction has been noted in trials. Of course, the large trials are still awaited. So, but this is a very promising drug. Some people have also started doing trials using ambroxol even in patients who do not have GBA mutation. and we'll see if those trials show any improvement in Parkinson's disease outcomes. So this is one potential treatment. So nowadays all young onset Parkinson's disease who have autonomic dysfunction, who have early cognition problems, even if they don't have, we are still sending all to look for at least a GBA mutation, because that has a role change in treatment. You'll hear a lot of stem cell therapies. A lot of patients get referred. There are few cases who have good response to stem cell transplantation. The one or two case reports are there. So this is a problem, right? So suppose this is the pool of dopamine neurons, and you add new neurons. What happens is that the pathology is still there. So synuclein deposition will occur even if the cells do get taken over, which is a big deal. The new cells will also get infected, right? So they also keep on getting damaged. So whether this just adding stem cells will be helpful, that is one thing which some people at Japan and Australia are working on. But in addition to that, if we know the genetic mutations and we can bring about a change in that as well, that will help in reducing neurodegeneration as well. So this is a long way to go, but there are some trials which are coming up. So this is something which is relevant to internal medicine graduates. So acute presentations in PD. So a very common picture: 65-year-old gentleman presents with history of fever, has dysuria and abdominal pain. So he's known to have Parkinson's disease, is on 3 drugs, and also a known diabetic. When you examine, the patient is confused, is blabbering, is delirious, but there is a lot of rigidity. So one thing that comes up in these patients is often whether the patient has a meningeal stiffness as well. But you find a renal angle tenderness, you make a diagnosis of pyelonephritis, start on antibiotics. So what to do about the confusion, what to do about the rigidity? Do you increase the dose, do you reduce the dose, what to do? Now, definitely you should not increase the dose, because levodopa can worsen psychosis as well. So a very common problem with any systemic insult, there can be a motor worsening, there can be a cognitive worsening. One very common thing to look for is neural malignant syndrome. So you do a CPK, you do a core temperature, make sure that the patient is not dehydrated. Look for any drug changes that have been there. So a lot of patients will have dementia, will have cognitive problems. They may forget to take drugs. Now, once the patient is with you, try not to change at least the levodopa part drastically. Keep it the same doses what the patient was taking. Anticholinergics is something that we may change. There are 2 reasons for this, in this case per se and in general also. One is anticholinergics will worsen cognition. So a person who already has started having delirium with infections is likely to have worse and worse cognition eventually. So that is one reason why we should consider stopping anticholinergics. If the patient is on the very high doses, we should not stop suddenly. We should maybe taper over 2 days and then stop. The other problem is this patient has come with a pyelonephritis. Again, anticholinergics will cause urinary retention, and that will lead to more infections. So that will cause more problems. So that's another reason why we should consider stopping anticholinergics. Other drugs we should consider to continue at the same dose. If the psychosis doesn't settle, then we may consider reducing levodopa or amantadine doses as well. So which antipsychotics to give if the patient is hallucinating a lot or has frank psychosis? So only 2 drugs are considered to be safe, which are available in India. One is quetiapine, so we should do an ECG and then before starting, because we may have to start quetiapine. And second is clozapine. The problem with clozapine is agranulocytosis, so we should do counts before starting clozapine. Most of the other drugs may worsen Parkinson's. So older drugs like haloperidol, even newer drugs like risperidone, they may worsen the Parkinsonism. So we should avoid those drugs. Then third drug, which is not available in India yet, is called pimavanserin, but when it becomes available, it's specific for Parkinson's disease related psychosis. So we should target that the patient sleeps at night, gets up in the morning, give good daylight, and slowly as the infection gets in control, the psychosis will also get reversed. That's all. Thank you. Are there any questions? So I would like to just before going, I would like to invite everyone to visit our department during your postings and all. Make sure that you see enough, because the diagnosis is largely clinical. You should have, if you see more and more patients, you will be much more confident, and it's very easy. But you should see enough patients. That's the only. Thank you. Sorry, Jenny.
Yeah. Thanks, sir. Thank you so much. Are there any questions? If there are no further questions, we'll close the session. So thank you so much, sir, for coming. Thanks, sir.